Record, hide the controls. All right, can you guys see the screen okay now? Everybody good with the screen? Can you see everything?
Yep, we can see it.
All right, cool. All right, this is normally a talk I give. Uh, I try and give pretty early in the year just because of the start of sideline coverage, and you'll see craniofacial injuries. And then I must have doomed myself because I was touching up my talk yesterday and adding some stuff that came up on my CAQ, and I went to cover games last night and I had multiple craniofacial injuries. So I guess I guess my timing for refreshing was helpful. Um, so I added in one of the things we were trying to do this year with our talks is add in some practical questions. So we'll go through. It is a little bit of a longer talk. Hopefully the ER guys are pretty familiar with some of these things, but I think it's pretty helpful to review kind of the sideline approach. So we're going to talk a little bit about how to deal with things when you're on the sidelines, and then we're going to really highlight eye, nose, ear, dental, and jaw injuries. Sadly, a lot of these are fairly common. We'll go through thinking about on the sideline. Obviously, the very first thing you do for a sideline evaluation is your ABCDs. Make sure from a head perspective somebody's okay. Make sure they're not complaining about any neck pain, or at least assess the C-spine if they've had significant facial trauma. And then your next goal should be hemostasis. As most of you know, when you see craniofacial injuries, especially with lacerations involved or the nose involved, there is a lot of blood. So yesterday we had somebody who with a facial injury who bled a lot, and then the kid tried to pass out because of all the blood. So sometimes you have to deal with hemostasis before you can deal with like truly assessing what the injury is and what you need to do about it. So thinking about kind of keeping the basics basic and trying not to get too distracted if there's something gory or nasty going on, and really just paying attention to controlling the blood before you assess people. And then probably one of the most important things to get into a habit of doing is looking at people from more than just face on head angle, especially if nose and eyes or eye sockets are involved. Just looking at somebody straight on, you can miss subtle things. So I try and always like stand to the side of them and look at them. And then also you want kind of um, like an inferior position, like if they are laying down, look at them from their feet, or try and look at them from the top of their head down towards their feet, because that anterior to posterior plane can be really subtle with changes. And if you're looking at somebody face on, you can't always see it. It's not always practical to lay somebody down. In some of these injuries, it's actually contraindicated to lay somebody down. So we'll kind of talk a little bit about that. And then really try and assess for any asymmetry before the onset of swelling. A lot of times with facial injuries, they swell pretty quick. So looking for any subtle asymmetry early is helpful. And then obviously bruising, and then controlling the bleeding and trying to assess where is the bleeding coming from can sometimes be a little tricky. So it's important to really take your time and assess these kids. You want to make sure you're palpating all the bones around the injured area, certainly for pain, but also for any instability, or if you can feel any crepitus that would be suggestive of a fracture. And then you want to make sure you're doing a really good neuro exam. So you're going to look, especially if it's up near the eyes, you're looking at motor function with extraocular eye movements, as well as sensation around the orbit. Super important to look at both those things. All right, so this is the question, are you awake yet? So which one of the following findings is not concerning for a fracture at the base of the skull? Raccoon eyes, hemotympanum, a halo sign, impaired extraocular eye movements, or battle sign. So I'll give you a minute to think while I respond to my neighbor. Anybody have any thoughts, or do you want to do process of elimination?
Well, I would eliminate A and E.
A and E. Okay, yeah. So those are probably the two most well-known um, concerning for basilar skull fracture. And that was actually a question on my CAQ was they had a picture of a battle sign and wanted to know what fracture it was associated with. So A and E you can eliminate. Anybody else want to eliminate another one?
It's not B.
It's not B, correct. So we've eliminated A, B, and E. Anybody know what a halo sign is? So a halo sign is if you have any fluid coming out of the nose, you can dab it like on a clear paper towel. And if there's a clear ring of fluid around the blood, it's concerning for cerebrospinal fluid leak. So you'll get like what they call a double ring sign, where the inner ring is the blood and the outer ring is the clear CSF fluid. So that one we're going to eliminate because if you have a CSF leak, then you are definitely concerned about a base of the skull fracture, which then leaves us process of elimination with impaired extraocular eye movement. Most of the time, if you have an impaired extraocular eye movement, you're looking more at an orbital fracture. Most commonly, probably floor of the orbit. So not really base of the skull, more specific to an orbital fracture. And this is a good question because it also follows my general rule is if you don't know and you can eliminate things, then the longer answer is often the correct one. So I didn't realize that while I was writing the question, but it definitely holds true here. All right, everybody awake now? We good? So skull fractures, obviously, these take large forces. I have never seen a skull fracture associated with regular sideline coverage. The only ones I've seen have been more traumatic, fall off golf cart, pretty nasty bike crash, unhelmeted, kids surfing on the hood of the car with friend driving, which didn't end well. So it tends to be pretty high force trauma. People can come in complaining of significant vertigo or tinnitus or hearing changes. Super important to always do an assessment of the tympanic membrane. If you see any blood collected behind the TM, certainly is more concerning. This is a picture of battle sign where you see bruising behind the ear. And then raccoon eyes is when you have kind of the double black eye look. And then the clear otorrhea or rhinorrhea is certainly concerning. Otorrhea, you're thinking about potentially fluid coming out of the ear. Rhinorrhea, you start to worry about CSF leak. So those things should all trigger prompt CT scan if you see any of those things. It's obviously an emergent evaluation if you think there is a basilar skull fracture. And in most cases, if it's depressed, it's surgical. If it's not a depressed fracture, then they just manage them conservatively. Return to play for most skull fractures are going to be minimum of 3 months off the bat. So sometimes we get kids from neurosurgery who get sent to us for concussion evaluation. But if they have skull fractures, we can almost always say, well, the neurosurgeon's holding you out for 3 months. So we're just here to kind of manage like school and life stuff. And then once you get cleared by neurosurgery, then we can talk about going back to sports. But they really need to be neurologically normal with no concerns and heal fracture before you're working them back. So they tend to hold people out quite a while. Eye injuries are a huge source of a problem, and there's been an expansion in protective equipment. So when I first started covering sports on the sidelines, there was no eye protection for lacrosse or field hockey. The lacrosse kids now consistently wear eye cages. The field hockey kids do not. But they do have like a padded face shield that they will put on during certain plays. But equipment has definitely expanded and eye injuries, like even in hockey, they've added more clear shield use than ever before. So if you see somebody with an eye issue, I had multiple questions on my CAQ about eye exam eye findings. So, visual acuity can be important to assess. So obviously it's hard to assess visual acuity on the sidelines. Most of the time, if I have an eye injury, I'm trying to take them into the training room to look at them because I think it's really hard to do a proper assessment when you're outside, especially if you can't dim the lights at all or it's a bright, sunshiny day. You really got to get them inside to assess them. So it's important to do a good pupillary exam using either your phone light or a pen light or an ophthalmoscope if you have one. The swinging flashlight test can be an important one to do because you're looking to rule out an optic nerve or a more central brain injury. So I had lots of practice questions about Marcus gun pupils. I did not have one on my CAQ about a Marcus gun, but you're essentially looking to make sure that when you do the swinging eye exam, if the opposite eye dilates when you're shining the light on one side, that then you get concerned that the message is not getting transferred over and you have a Marcus gun pupil. Extraocular eye movements are super important. So making sure if there's anything where there's been trauma up around the upper half of the face that you're assessing to make sure they can move the eyes in all planes and they are not getting any double vision. You want to palpate around all surfaces of the orbit as well as the nasal bone, and then check for sensation. If there's any numbness around the eye, it's pretty specific for an orbital fracture. And in most cases, you're looking to do a fluorescein exam to look for any corneal abrasions and a fundoscopic exam to get a better assessment of the retina, optic nerve, and macula. Not everybody carries a portable ophthalmoscope. If you have one, it's really a nice, handy thing to carry on the sidelines. I have a portable ophthalmoscope otoscope that I got way back when at some point, and I still use it on the sidelines. So it's a pretty handy device to have. Nobody on the phone call is an old person like me. This is Killian knows this guy because he's a Detroiter and a hockey fan. So this is Steve Yzerman. He played back in the day in Detroit. Hall of Fame hockey player, famously with one nasty eye injury here. So we're going to kind of review a whole mess of eye injuries. We're going to go through corneal abrasions, foreign bodies, just ecchymosis or bruising, conjunctival hemorrhage, hyphemas, globe rupture, orbital fracture, lens dislocation, and retinal dislocation. And I'm going to apologize if we have any noise. I have some workers coming to the house, so hopefully they won't bother us too much. So corneal abrasion, super common, probably 10% of all ER injuries. We've probably all, unfortunately, had the pleasure of having one of these. It comes from a mechanical blow to the eye. Probably the most common in sports would be fingers, but also we'll see trouble with turf. Pellets are now made of not just rubber, but some are more sand-based. So you can have an abrasion from any of those or other equipment that's involved, stick, for instance. So obviously sports with no eyewear are at highest risk, and then people who wear contacts, because the contact can trap a foreign body and then drag it under the eye. So if any of you have had one, you know how uncomfortable it is. It feels like you just have something in your eye and you can't get it out. It causes you to tear a lot because your eye is trying to eject whatever is in there. And then a lot of times people will get some sensitivity to light with it. If you have some portable fluorescein strips, it can be really helpful. If you fluorescein people, I usually try and warn them that they're going to get some yellow stuff out of their nose because of the drainage. And if you identify a corneal abrasion, then in most cases, we just do topical antibiotics and have them not wear their contact lenses. And then once they're comfortable, return them to play. This is another hot topic for CAQ. I don't know why they love asking about corneal abrasions, probably because they're common. I did not have any questions on this, but they'll often ask you about patching. Oh, hold on, skipping ahead. And in most cases, people say not to patch one. So foreign body in the eye, we see it more and more with the turf. So outdoor sports are highest risk, but certainly we see it in people who do stuff on the regular road, occasionally runners if they're not in eye protection, or people riding a bike. And then again, it's a very similar feeling to a corneal abrasion. So you want to assess patients with that foreign body sensation in the same manner. Using fluorescein, you're looking for any linear lesions. And it's super important to rule out a foreign body if you find a corneal abrasion. So you want to make sure you're really flipping the eyelids and having the eye move all over so that you can make sure that you can identify anything that's a foreign body that may be trapped under the eyelids so you don't miss it, so it doesn't keep scratching people up. You always want to remove contacts. You can do some topical anesthesia drops if you have them. Make sure that you're rinsing the eye out well if you can for irrigation. And then you never want to use like a needle to try and get the foreign body out, but a moistened swab, like a moistened Q-tip type swab, works really well for trying to catch the foreign body and get it out. And then a topical antibiotic ointment can be soothing and help prevent any issues with infection. And if you can remove the foreign body and they're comfortable, you can send them right back to play. If they have a secondary corneal abrasion, you usually have to hold them out. So ecchymosis, just kind of standard eye trauma where you take a blunt force injury to the cheek. If once you're comfortable and you've ruled out concussion, you've ruled out concern for orbital fracture, and you've ruled out basilar skull fracture, this is really your process of elimination going all the way down to just ecchymosis or bruising on the face. You can do ice and pain medication. And then the most important thing is not returning people to play if the swelling's so severe it's causing them any visual field defects because their vision is obscured. If they're at the point where they have loss of visual fields, then you want to make sure that you're holding them out because really in order to protect themselves on the play field, they have to be able to see in all directions comfortably. Subconjunctival hemorrhage we've probably all seen, and this probably freaks people out more than any of the other, kind of minor eye injuries because it's so visible where you get this superficial layer of blood within the subconjunctiva. It can happen to people with blunt force trauma on the football or other sports field with the fingers to the eye. In basketball, we see it a lot. LeBron had one famously during the NBA playoffs where his eye just looked like this and people were freaked out that he was playing. Um, Athletes with hypertension, or if somebody has like bouts of GI viral illness or they're sick with lots of vomiting for other reasons, you can have conjunctival hemorrhages. But most of the time, as long as they've got nice, normal acuity and no foreign body and they're comfortable, you can send somebody back to play. It does not affect their vision at all. And I warn people that this can take several weeks to reabsorb and not to worry about it because it definitely causes a lot of panic for people. So case one, this was me, by the way. This was my first college football coverage in fellowship. So kickoff of my very first college football game, kid runs down the field holding his eye after covering on the play, states he was poked in the eye during the play. I'd just seen him and done his PPE the week before, and it was boring. I knew exactly who he was. He reported change in vision in the injured eye, and so we took him into the training room to try and get a better look at him. Fluoresceined him, it's negative, and then get out your ophthalmoscope and you look at him, and all of a sudden you see this. So does anybody know what this is?
A high FEMA.
Yes, that's a hyphema. So anybody know how to treat it? So choices are A, start topical antibiotics, put a patch on it. B, return them to the game. C, have them see optho later this week. Or D, send them to the ER for an optho consult.
Send him to the ED.
Yep, so this you want to send to the ED. This is a hyphema. My patient had failed to disclose on his physical form that he had an undiagnosed platelet disorder. And when he went to the ER, he had platelets of 6,000 while on the football field. So he did not play another college football game after taking one kickoff in his college career. And his one play left him with a hyphema. So the answer, again, longest answer out of all of them, send him to the ER immediately for optho consult. Does anybody know how you transport him? So these people should go by ambulance and they should always be upright. And that's important. You don't want people laying flat with this. And I usually recommend you go by ambulance because people aren't always trustworthy. And I often will call ahead to the ER so they know optho needs to come in. So another common question is, and this was on my CAQ about transporting him to the ER. That was a pretty similar question to one I had. Sometimes they ask about where's the blood accumulation. This is an anterior chamber accumulation of blood, so it is fairly visible if you take a good look. And the most common complaint people will have will be essentially it's like a curtain coming up from the floor with their loss of visual field because that blood's just rising and they can start to lose their vision from the bottom up. It comes from blunt trauma. Contact sports and ball sports are the biggest culprits. And it's super important that you rule out worse problems such as an orbital fracture, concussion, globe rupture, any of those things. So when you transport them, you want them upright. A lot of times people will put an eye shield on them just so they don't have other trauma to the eye. And then you want to make sure that they're obviously following up with optho. The biggest risk is having an increase in eye pressure, which is why optho needs to see them and follow them. Case number 2, your college basketball team goes and plays paintball for a team bonding event, and the captain of the team calls you panicked because the starting center got hit in the eye with a paintball, and he now is having some vision trouble and his eye looks really bad. Of note, he was just being non-compliant with his protective eyewear at the time. He thought he was too cool for it. So paintball normally has protective eyewear, but this guy did not want to wear it. So you tell the captain, get him to the closest ER, and you meet them there, and the guy has a teardrop pupil visible. So anybody know what diagnosis is most likely associated with the teardrop pupil?
Globe rupture.
Yeah, globe rupture. So this was also on my CAQ. So you have other, oh, see, I gave you options and you got globe rupture off the bat. So orbital fracture, hyphema, globe rupture, corneal abrasion. Oh, I highlighted the wrong one. Look at that. See, good thing you know the answer. It is indeed globe rupture. So globe rupture is a disruption of the eye wall, usually from direct trauma. They can look absolutely nasty like this photo, but in most cases, we'll find more subtle findings in things like a BB gun or a direct blow from other flying objects can get people. So when we have no eye protection in sports like field hockey, people are at risk, but most people have immediate onset of eye pain and visual changes. So it's pretty easy to know that this is an automatic go to the ER, but that subtle finding of an irregular pupil, and in particular, a teardrop shaped pupil, is an absolute indication for getting to the ER, and calling ahead to have optho present when they get there is ideal. These people need a good slit lamp exam, often need a CT scan to check not only the globe, but also the surrounding bony structures. Again, this is always a transport them upright, put them in an eye shield so they have no other trauma to the area, and you don't let these people eat because they're likely about to lose their eye, in which case return to play becomes guidance based on monocular athlete guidelines for return to play. So there's lots of sports where if you have one eye, you cannot play. Orbital fractures are high risk. Probably the most common ones I have seen have been in basketball with an elbow and soccer with a header where somebody misses the ball and hits somebody else's face. You can have a fracture of any one or multiple bones, but assaults are still way more common than sports for causing these injuries. You can also have an orbital wall fracture due to an injury from the eye. So as opposed to direct trauma to the rim, that wall, especially posteriorly, can get fractured if the eye has direct trauma and then essentially causes high pressure going posteriorly. So this is a great example of why you want to always look at people from 2 angles. If you just looked at this person face on, you won't notice like that subtle depression. The medical term for that is N-ophthalmos as opposed to X-ophthalmos, where it comes more out towards you. And that kind of sunken eye can be really subtle, and that can be an indication of a posterior wall orbital fracture. So looking at these people laying down can be really helpful. Most common sports, baseball, football, basketball, racquetball, and making sure these people don't have double vision, checking extraocular eye movements. And if anybody has limitations in their extraocular eye movements, you worry about muscle entrapment. And then checking sensation around the eye socket, super important. But again, this is something that needs to go right to the ER if you have suspicion. Plain films are negative about 50% of the time, so CAT scan is the most important. Again, you want to transport these people upright. Really important to tell them not to blow their nose or to like bear down, which seems kind of like a weird thing to tell somebody, but you're at risk for getting orbital emphysema. So you want to transport these people upright. They often don't need surgery, but when they do, it's because of either a large fracture or if there's muscle entrapment or that posterior wall fracture, which results in N-ophthalmos, are all indications. From a return to play perspective, again, you're looking kind of minimum 6 weeks. You're looking to follow those monocular athlete guidelines if they have any vision loss or restrictions in range of motion. And when people go back, we do typically require eye protection, but you can work them up with light training once they're more comfortable around 3 weeks. Lens dislocation. So this comes up on CAQ in regards to Marfan's. They'll ask you about major versus minor Marfan's criteria, or they'll give you a case about somebody who has a lens dislocation, and they may ask you what underlying diagnosis puts them at risk. So this is a subluxation or dislocation of the lens due to disruption of the ciliary body. Usually blunt trauma related can happen spontaneously in people with Marfan's. It's pain-free, and just a subluxation may be unnoticed, but a dislocation can cause a complete vision loss. So anybody with a sudden onset complete vision loss, this has to be on your list. You can have pressure increase from aqueous drainage getting blocked. So these people, again, need a dilated eye exam. Certainly anybody with sudden vision loss, you're likely sending to the ER anybody and calling ophtho, but it's just important to recognize that you worry about the eye pressure again. So you're going to be sending them upright in most cases. Retinal detachment can come from a direct trauma to the globe. Occasionally, it can be spontaneous. When we see it, people will sometimes report like an abrupt onset of floaters, or they'll have flashing lights, but not be a person with like a history of auras for migraines. So anybody having flashing light syndrome or abrupt onset of floaters is worth sending to the ER to get evaluated for this. They tend to have more peripheral vision loss than central, but they can have like a curtain deficit coming from the top down as that retina detaches. So these people, again, send them to the ER, and oftentimes they end up seeing a retinal specialist. All right, that is it for kind of eye and surrounding structures. Any questions on those?
I guess from like a practical standpoint, so obviously for any of the major eye injuries, we're sending them to the ED, but if you're on the sideline and feel like you can't get a good exam for like corneal abrasion or things like that, how are you following up? Are you like still sending them to the ED, or would you just have them follow up in clinic? What do you typically do?
So if it's just more corneal abrasion, like most of the time a lot of the athletic trainers will carry the fluorescein. So that's usually not bad. If you're mostly worried about making sure you can get a foreign body out if it exists, if you can't get it out because you don't feel like you have the right tools to flush a foreign body out, or, then I think you're kind of stuck sending them to the ER. I think kind of like the eye bruising where you don't think there's a facial fracture, foreign body, and corneal abrasion. You can pretty much manage those on the sidelines as long as you feel comfortable, unless they have like a complaint of vision loss, which has you more worried. If they're just like pain and uncomfortable and you're pretty confident there's no foreign body in there and it's more just corneal abrasion, then you can just manage them, send them in some antibiotic, and have them like chill for 24 hours and check back with them as long as they're not having any visual changes.
That makes sense.
Anything-
Thank you.
Yep. Anything else about eye? Most athletic trainers will have like eye wash too, which can be helpful. All right, nasal injuries. So there's two areas where people can bleed from. Sphenopalatine is the more posterior, and Caesalbach's complex tends to be more anterior. Those posterior ones can be really problematic to stop the bleeding. And occasionally a nosebleed can mask a more serious injury. So certainly when we see a nosebleed, you always want to be ruling out injuries to the head in terms of concussion or anything else more concerning. People are at risk if they have allergic rhinitis, chronic sinusitis, they use topical nasal steroids consistently, dry weather, they have a history of nosebleeds, or they have an underlying bleeding disorder, or they have poor facial protection, which is unfortunately a lot of sports. It's almost always blunt trauma, so head to head, elbow to head, ball to head. We see it in lots of things. The most important thing is trying to see if you can visualize the source. If you can't control the bleeding, sometimes if it's posterior, kids will start getting like really nauseated and they may cough or spit up blood or throw up blood because it's running down posteriorly. You can do that ring test where you just dab the blood on a paper towel to make sure there's no evidence of a CSF leak with a halo sign. And then it's really all about direct pressure. If you're pretty confident it's an anterior bleed, most of the athletic trainers carry nasal tampons, which you can essentially put a little bit of Vaseline on and just shove up the nose and see if you can't get it to slow down. I'll often put an ice pack on the back of people's necks. Sometimes that helps, and then have them just do like a direct pressure squeeze, and I'll have them sit there and hold for like a solid 10 minutes without checking, and that usually takes care of the problem. If it's a posterior bleed, then sometimes you just have to send them to the ER to get it better controlled. If you can get them the nasal bleeding controlled, you're convinced they don't have a concussion, and you can get them decontaminated with cleaning up all the blood, and they're doing well, then oftentimes you can send them back in safely the same day. You obviously want to check them for a nasal fracture. The most proximal half of the bone is bony, and that's where we tend to see the nasal fractures. Again, looking from the foot of the bed up can really help. You're looking for any sort of other facial bone fractures around the area. Sorry, my dog's going to bark for a second. And then you're looking to rule out concussion. So the one thing I try and teach people to look for is a septal hematoma. So this is a collection of blood that can form within the septum in conjunction with the nasal fracture. So you can see on the right side of the screen, which is the left nares for this patient, they have that big bulbous looking swelling in the nares. And that's something that needs drained by ENT. So if at any time you see somebody with a nasal fracture and they accumulate that blood there, you need to make sure they're getting checked out. They can be very tender along their nasal bone. I don't routinely send people to the emergency room from the sidelines with a nasal fracture that's non-displaced. If they are displaced, I will often send them right down to the ER to try and have them reduced and splinted. It's just so much easier to get somebody in with ENT if they go through the ER and they get reduced and splinted. Most of the time, if you're concerned about a nasal fracture, and there's any consideration for surgery, doing it within the first 7 to 10 days is really important. So the septal hematoma does put people at risk for having a saddle deformity because of necrosis at the cartilage. So this is what you're trying to avoid. So always make sure you check for a septal hematoma. And if they have a septal hematoma, that's for sure a go to the ER and call ahead and request ENT so the ER docs know exactly why you're sending them down there. So most of the time CT scan is the best way to see a nasal fracture. Plain films have a pretty high false positive rate. Like I said, if you've got a non-displaced nasal fracture, most people do nothing. If you're displaced, then immediate reduction, really you want to do right away. If you delay reduction, ENT does not like to operate. And I usually say ENT should be doing the reduction. You don't want to try lining people up on the sidelines. So if you have a non-displaced fracture, some people in the ENT world will let people go back within a week with a face shield. You can buy a lot of off-the-shelf face shields just from Amazon, and people should stay in the face shield for the season, but you're really trying to prevent any sort of ongoing trauma. For those of you who cover wrestling, you may start to see these. These are cauliflower ears. Hopefully they're becoming less common because people are being more compliant with their ear protection, but sometimes the ear protection slips off or kids are just stubborn and don't wear it. This is a collection of blood within the cartilage and the perichondrium. You get essentially like a little superficial tear between those two layers, and blood can collect there, and that tearing comes from like a shear force, most commonly from like the ear hitting the mat and then getting dragged. Having a prior auricular hematoma puts people at risk for them. But if you have friends who wrestle or do MMA and you look at their ears, a lot of people have these. You can have that deformed look to the pinna that just never goes away. And the most important thing to know is these need to be drained as soon as possible. Otherwise, the blood just coagulates and it's near impossible to evacuate without surgery. So ENT will often see these people right away if you have one. This is something where you often have to like direct message the doc, whoever's on call, and try and get them in, because if people just call ENT, they'll never get in for this. You essentially have to pack the area and then have pressure that stays on once you drain them. So just cleaning them off and draining them on the sidelines does no good because they will absolutely reaccumulate. So ENT will often sew in a button, or they will sew in some padding around the area to provide some compression after they drain them. And then you have to really keep that pressure dressing on for a full week, which people are really horribly compliant with because nobody likes this giant wrap. I mean, most of the time you leave there looking like, a military person injured on the field, where you have like this giant wrapped gauze around your head with a giant padding around the ear. So the pressure dressing's not much fun. If you can get the auricular hematoma drained and within a week it's not reaccumulating, we'll often send people back, but we give them guidance to avoid further trauma. All right, so this was my night last night. I pulled into the parking lot about 5 minutes early for my soccer game, and there's field hockey going on the same time. And the field hockey game had started before the soccer game, and I got there and the athletic trainer was calling me like, can you just come to the field hockey field? I have somebody for you to look at. And as I got out to the field, I could see her at midfield by the scores table with a kid laying down, and she was holding the kid's feet up into the air. And I was like, my God, why did a field hockey player pass out? What is she doing? So this kid actually took a stick to the mouth right before I got to the game, and she proceeded to bleed profusely from her mouth and then got weak and started to feel like she was going to pass out from all the blood. So they laid her down. And she was with it when I got there, and they had the bleeding fairly well controlled, but they hadn't really assessed what was going on in her mouth yet because she was trying not to pass out, and they were trying to keep her from not passing out. So you could see underneath her lower lip line, she had multiple exit wounds from what looked like teeth puncturing her gum. And then we were able to kind of peel back her lower border of her lower gum, and you could see she had a very large, jagged, open wound that was through and through the bottom lip. And then she had 2 secondary teeth, which had been chipped. I'm skipping ahead here. So she's got this large, jagged, deep internal mucosal laceration. So what else needs checked? Okay, so her teeth. So she has 2 chipped secondary teeth. Okay, she's 16, so she's lost all of her teeth. So she's got her adult teeth with 2 of her bottom teeth chipped. And then another bottom tooth, which looks maybe crooked, but I don't know what her teeth looked like before. And as I start looking at them, the mom's like, I don't understand how she hurt her teeth if she has her mouth guard in when she's playing. And the answer is, this is the kind of mouth guard she's wearing. So this mouth guard only protects your upper teeth. She did not have a full mouth guard in. She had one in to protect her upper teeth, and she managed to put her lower teeth through her bottom lip. So we found 2 chipped bottom teeth and one that was definitely loose and looked a little angulated. So what do you do next? An idea? So best thing to do is just send her to the emergency room. When you have like a really complicated internal mucosal laceration, for sure one that goes through and through, as well as a tooth that's loose. She's going to need to get one sutured, have the layers sutured and closed. 2, she's going to need the loose tooth splinted, and then she's going to need oral antibiotics with that through and through wound. So a lot of times dental needs called. So this is one where you call down to the ER and you tell them to notify dental. They're going to need to come in because most of the time they take a while to get there. If the person's super young and this happens, or if you have any change in mental status with the patient and you have pieces of teeth which are missing, you should always do an x-ray to try and figure out where the piece of tooth is to make sure they didn't aspirate it. This kid had 2 teeth missing and we only found a portion of one of the teeth. Now, I was not out on the field when she got removed. So I don't know if she left, at the time, I didn't know if she left that piece of the tooth out on the field or not, but we just had the little tip of one of them and the other one couldn't be located. And when she got to the ER and they started cleaning out her wound, they found the other piece of tooth deep in the laceration that went through and through. So they located it, and which was good. And she did have an x-ray done of that mandible reportedly to make sure she didn't have any fracture of the jaw, but she was not really tender there at all for me. So she had her wound closed, she got oral antibiotics, they braced her, and then I always tell people as soon as you have a loose adult tooth, get ready because you're going to end up with a root canal down the road. Speaking from experience, so dental injuries are super common, and the most common are anything where you can have a direct blow to the face. Statistically, they say skateboarding, gymnastics, swimming, ice sports, squash, bicycling, and inline skating put you at highest risk. I would disagree with this list completely. That's a textbook list. I mean, we see it all the time in sports. So really, the American Dental Association recommends a mouth guard for any contact or collision sports, and very few people wear one. So there's multiple types of mouth guards out there. There's just a stock mouth guard, kind of like what she had in, which you just slip into those upper teeth. Boil and bite are super common, like that top one where you just drop it in boiling water, you take it out, you wait a minute, you have your athlete bite on it to imprint their teeth, and then they put it in. The one common thing that happens with boil and bite is kids like to go and cut off the back portions of their boil and bite because they don't like it going all the way in the back of their mouth, and they'll just use it to protect their front teeth. That puts people at risk. And then a custom molded one like the one on the bottom where people actually make one with the dentist or orthodontist offers the most protection. So tooth injuries fall into a couple different categories. Subluxation is very common with a loosened tooth. An intrusion where it gets driven into the socket is common. An extrusion where there's a dislocation with neurovascular damage is common. An avulsion where it fully pulls out of the socket is common. And pretty much any of these should see a dentist, but the only true emergency is if you have an actual avulsion where the tooth comes out of the socket. My kid needed to go to the ER because she didn't only have that loose tooth, but she had the complicated through and through wound of the mouth. So if she had just had like a slightly loosened tooth without the other things, I probably would have just had her see dental this week. So an intrusion is when the tooth gets pushed in, usually due to some impaction or direct trauma. Sometimes you can have like a forceful closure of the teeth that causes it, or a direct object hitting the teeth is more common, again, due to poor mouth gear. They'll have a sensation of the teeth feeling misaligned, and oftentimes you'll see the tooth shortened, and then these kids usually need to see dental pretty quick so they can have the tooth repositioned and splinted. An avulsion is when it comes out completely. This is super important to know about. This is one of those things that can absolutely happen to you on the sidelines. And if you know what to do properly, you can potentially save that kid's tooth. If you see an empty socket sitting there and you can find the tooth, it's really important to try and re-implant it as soon as possible if it's an adult tooth. If it's a baby tooth, we do nothing for it, so don't stress about it. But if it's an empty socket with an adult tooth and you locate the tooth and you can get it back in under 30 minutes, it actually is a 90% success rate of surviving. If you wait 2 hours and you send the ER with the tooth in a container, it's probably not going to survive. The most important thing is you want to hold it by the tip or the very tip of the tooth. You do not want to hold it at the base. That's where the roots of the tooth are. If you grab it at the base, you stand a chance of damaging the roots. You don't want to scrub this thing clean. If it falls on the ground, you literally pick it up by the tip. You try and rinse it off, ideally with some saline or sterile water if you have it. Don't scrub the tooth at all. Try and identify where the front of the tooth is and then put it in with some minimal pressure. And then you need to essentially have it held in place there while the athlete goes for emergency dental evaluation, because it needs splinted into that location. So as long as the patient is awake and they're not having any issues with a head injury that's affecting their mental status, you can usually give them a piece of gauze, put it over the tooth, and just have them hold it in place there. If there's any concern about the athlete's mental status, you never want to put the foreign body in their mouth because they're high risk for aspirating. But these kids need taken care of right away. If you have somebody who's unconscious or who you can't trust because of their age or their level of consciousness with mental status, then putting it in a save-a-tooth container, which has a balanced salt solution, is the best thing to do, and transport them to the ER. Dental's available at main campus. So I tend to send people down to main campus for dental injuries because I think they get handled a little bit quicker with the dental team coming right in. If you have a partial break of a tooth, we categorize them into simple, which is no pulp involvement, versus complex, where you can see the pulp. So my kid last night had one simple fracture and one complex fracture. If you're broken at the tooth down to the pulp, it's very painful. You'll see visible bleeding. A lot of times you'll see that pink reddish dot within the yellow dentin of the tooth, but it's really much more painful than if you just chip them. If you chip the tooth and it's a simple one, tends not to hurt. So here's a nice picture of a simple fragment. They do say you can save the tooth fragment. In most cases, if you've got a simple fracture, there's nothing that they're going to do except rebond the tooth down the road and not use a fragment. If you've got a complex fracture, occasionally they'll try and save them, but most of the time they can't. The only time they use the tooth fragment that they find is if it's a complete avulsion. All right, moving on to jaw and TMJ dislocations. So jaw injuries are usually due when you're thinking about a TMJ dislocation due to a direct blow when the jaw is partially opened. Some people have a real shallow fossa, but the people who are really at risk for these are people who have underlying laxity, like Marfan's or Ehlers-Danlos. I have a kid who I've been trying to manage who's having pretty significant pain in his bilateral shoulders and the whole shoulder girdles in general. And when I started assessing him for like a hypermobility syndrome, I was like, well, can you pop out like any other things? And he's like, oh yeah, look at my jaw. And he can literally sit there and like pop his TMJ in and out on his own, just moving his jaw around. So these people, are definitely higher risk for having a TMJ dislocation. If you are not ligamentously lax and you have TMJ trauma, and you can dislocate either on one or both sides, and the jaw tends to look malformed. They tend to have an underbite. They have a hard time speaking. They feel like their jaw isn't shutting right. And you can see kind of in this picture where that condyle has slipped out of the location where it's supposed to be, and you get an underbite because it comes anterior. You can try and reduce these. So they say to put gloves on. Essentially, you're just going to stick your thumbs way into the back of their jaw. And on the bottom portion of the teeth, you're trying to push down and essentially get those condyles to clear. And sometimes you can get it to clunk back into place reportedly. I've never had to reduce one, which makes me happy. But there is a high risk of a mandible fracture in association with these. So if you're ever reducing a TMJ dislocation, I tell everybody attempt once and once only, but even reducing it puts somebody at risk for having a fracture. So sometimes it's best just to send them to the ER. You can have multiple locations of fractures. So most of the time, these people need a good head CT where you're doing all the bone pictures to get a good look for fracture. They can present with numbness of the lower lip, trismus, malposition sensation, or feeling like they can't close their bite down appropriately. You always want to check the airway. These are high force traumas, so you want to make sure you're screening for any basilar skull fracture signs, vertebral artery dissection, concussion signs, and then most of these kids end up with like a panorama view x-ray also. Because people worry about eating when they get reduced a lot of times. If they have any wiring, they're going to get put on a soft diet for a while their fracture heals. Ooh, and we tore through that. So that's it. Questions? A lot of info, a lot of very dense CAQ topics. I usually like to do CAQ stuff closer to the end of the year. But this one's so practical for sideline coverage. I try and do it early on. All right, no questions. Everybody awake? All right, folks. Yeah, question, Heather?
Oh no, I was just gonna say thank you.
Thanks, Sus.
All right, everybody enjoy their long weekend. You should all have Monday off. None of the clinics are open, so there should not be training rooms at schools on Monday. So make sure you take the day off to enjoy yourself. And I'll see you guys all next week.
Thank you.
Yep.
Thank you.
Thanks.